Chapter 27b, the female reproductive system. Once again, this lecture will contain Wikipedia images of genitalia, so it may not be suitable for all of your coworkers. In this first section, we'll be talking about birth control pills and how oral contraceptives work. We'll also talk about other forms of birth control and talk about any dangers, there really aren't, and other uses that they may have. That will lead us to the topic of endometriosis. We'll have to learn what this is, where it's located, and how it can be treated. We'll talk about why women menstruate. I won't actually have a very good answer for this, but we'll talk about the process of menstruation, and then we'll move on to pap smears and discuss who should get screened, starting when and why. To do all of that, we'll be focusing on the external and internal organs of the female reproductive tract and discussing some of the physiology of how their functions are coordinated, namely the uterine cycles and later the ovarian cycle. Let's start with the female gonads, or the ovaries. Just like the testes, the ovaries have two major functions. The first is to produce the sex cells, in this case oocytes, and the other is to produce sex hormones, in this case estrogens and progestins. They also secrete the hormone inhibin, which we'll talk briefly about, but it has the same function as in men. The ovaries are located on the underside of the abdominal cavity, and therefore are covered on top by visceral peritoneum, which covers a layer of connective tissue called the tunica albuginae. This is the same layer that we saw in the testes. The inner portion of the ovaries is called the stroma, which includes both a deeper medullary region and a more superficial cortical region. It's out in the cortex that the gametes are produced. The production of those gametes begins before birth, but then takes a break. Ovulation of the oocytes doesn't begin until much later during puberty and ends at menopause. So this is very different from the male reproductive system. The production of eggs begins before birth. The stem cells will enter meiosis, but halt during meiosis 1, and will not begin again until puberty. So this is very different from the male reproductive system. Between birth and puberty, a large number of those primordial follicles, the cells that will ultimately develop into eggs, are lost. And so beginning at puberty, there's roughly 500,000 or so primordial follicles that could continue with meiosis to form eggs. Because they haven't finished with meiosis, we can't call them eggs yet, but we'll call them oocytes, and they will remain in a state of suspended animation until puberty begins and the pituitary begins producing FSH. This will trigger roughly 1 or 2 of these oocytes to be ovulated every month or so. Because all of the stem cells undergo meiosis before birth, women will have a limited number of eggs that they can produce. This is in contrast to the male reproductive system, where mitosis continued the regeneration of more stem cells. In addition, when one of these stem cells begins meiosis, it does not produce 4 mature sex cells, but only 1, and then 3 unused cells known as polar bodies. These unequal cell divisions mean that one cell keeps all of the cytoplasm. It's got more cytoplasm than your average cell. And then I've got 3 remnants, which are really no more than waste buckets for some extra DNA that was not needed. Development occurs within the cortex of the ovaries, in specialized structures called follicles. At the center of each follicle is an oocyte in one of the various stages of meiosis, surrounded by a number of follicle cells, which are similar to the nurse cells in the testes that help promote and drive differentiation and meiosis of these oocytes. The follicles will go through a number of different stages, which different books will name differently. I am going to give you my favorite way, which is I think the easiest way, of assigning names to the various stages of the ovarian cycle. We're going to start off with a primordial follicle. This is just an oocyte surrounded by the connective tissue of the ovary. A primary follicle is one oocyte plus a single layer of follicle cells. If these follicle cells undergo mitosis, we'll ultimately wind up with a secondary follicle, which is two layers of follicle cells surrounding an oocyte. And as these follicle cells continue to divide, this will produce a Graafian follicle, which is a single oocyte surrounded by a number of follicle cells and includes this fluid-filled chamber here called the antrum. It takes several months for a primordial follicle to develop into a Graafian follicle. However, they do not all start this process at the same time. FSH will drive the development of a few dozen primordial follicles every month. At some point, however, in a 1-month time span, some primordial follicles will begin maturing and others will finish maturing. And for the next few pages, we're going to pretend like it only takes 1 month for this primordial follicle to develop into a Graafian follicle. Just keep in mind, we're not really talking about the same follicles. The ovarian cycle is the time that it takes the ovaries to make and ovulate an egg. It takes roughly a month. However, when we're talking about days of the ovarian cycle, it's not the same thing as the days of the month. This could begin at any point. Nevertheless, on the first day of the ovarian cycle, LH and FSH levels are low, but they will stimulate the maturation of some of the primordial follicles, which will develop into primary follicles. FSH is the hormone that drives follicular development. With more follicle cells, the LH from the pituitary will stimulate them to produce more estrogen, and hence with more cells, estrogen levels will continue to rise through the first portion of the ovarian cycle. Progesterone levels, however, remain low. As the follicles continue to develop, we have even more follicular cells, hence estrogen levels rise further. Up until this point, estrogen has been inhibiting the release of LH and FSH. Therefore, levels of these hormones in the blood remain low. However, the pituitary has still been producing these hormones and storing them. As more and more follicles continue through development, ultimately, 1 or 2 of the follicles become dominant and cause the destruction of all of the others. By day 7, there should just be 1 or 2 follicles continuing in the later stages of development. After ovulation, the follicle cells of those Graafian follicles are no longer connected to an oocyte, and so their job is going to change. Instead of producing just estrogen, they now secrete estrogen and progesterone. Therefore, progesterone levels in the bloodstream will increase during this second portion of the ovarian cycle, which we now call the luteal phase. Progesterone has 2 important functions. It will change the lining of the uterus, but it also shuts off GnRH production from the hypothalamus, which means that LH and FSH levels will be low. Hence, another ovulation event will not be occurring during the luteal phase of the ovarian cycle. In the absence of fertilization and implantation, the decreased levels of LH will mean that the corpus luteum will stop producing estrogen and progesterone and will dissolve into a bit of scar tissue known as the corpus luteum. With the drop in estrogen and progesterone, the ovarian cycle is prepared to start again in the next month. The pill refers to one of many different combined oral contraceptives, medications which contain both estrogen and progesterone. There are other forms of birth control pills and even other delivery methods, but they all center around adding progesterone to the female's bloodstream. If she has constant progesterone levels, this will inhibit GnRH production during the entire month, which will mean that LH and FSH are not produced. And without those hormones, ovulation cannot occur, and the development of follicles cannot occur. Without GnRH, then estrogen levels will be low as well. This means even though a female might be taking estrogen in those pills, her actual estrogen levels in her bloodstream might be lower than they would have been had she not been taking an estrogen pill. Here in the United States, we have a lot of hang-ups about sex. This has led to a lot of hang-ups about the use of birth control pills, which has resulted in the distribution of a lot of misinformation. So let me go through some of the facts about the use of birth control pills. One of the risk factors for the use of birth control pills is breakthrough bleeding, which will make more sense after we've covered the uterine cycle in the next section. Another risk is thromboembolism and stroke. This comes from research done back in the 60s and 70s. However, newer forms of birth control, the ones that your patients might be on, have much lower doses of estrogen in them. So this is more of a historical note. It is not current medical information. Estrogen can promote blood clotting. This is in fact very beneficial during childbirth. That's when estrogen levels would be super high, and during birth there is a significant amount of bleeding. So by increasing the capacity of the bloodstream to form blood clots, a pregnant woman will be at a lower risk of bleeding out during a difficult child delivery than she would had she had lower levels of estrogen. Nevertheless, people still refer to these old studies in an effort to scare people today, as opposed to providing them with accurate medical information. Another one of my favorite scare tactics is especially useful against younger women, and that's the threat that birth control pills might cause acne. Well, it's true. Estrogen and progesterone can mess with the sebaceous glands in the face, but some birth control pills can actually reduce acne. So which is it? Do birth control pills cause acne, or do they reduce acne? And the answer is yes. Yes, they do. There's no way to predict how one individual woman will respond to a specific brand of birth control pills. And if she has an adverse reaction in the form of acne, there are enough other brands that it's easy enough just to switch to a different one and see if that is better tolerated. Nevertheless, we are very certain that birth control pills do not cause cancer. Now, recently in 2017, there were signs that birth control pills might increase the rates of breast cancer, but the numbers were very small and more than offset by reductions in other cancers. So, the bottom line here is that women who take birth control are not more likely to die of cancer. It's still a bit of a confusing story, one that could be pushed in either direction depending on whether you are pro-birth control or anti-birth control. Still, life expectancy might not be the best metric here. If that was really all we cared about, how long women are going to live, we should tell all women to go on birth control pills. Because the data here is very clear. Birth control pill usage increases life expectancy. And that's because there are risks with pregnancy. Some women will die in childbirth. In fact, a relatively large number of women here in the United States are going to die during childbirth, much more than any other developed country. Still, as I said, Life expectancy is just one metric. If we told all women to go on birth control pills starting at puberty until menopause, there wouldn't be any births. And that's a choice that some women might want to take. They might want to take on the risks so that they could raise a family. So life expectancy is one metric, but quality of life is another metric that we should definitely take into account. Nevertheless, if people are using life expectancy as an argument against birth control pills, they're just plain wrong. It's not backed up by science. During the end of the luteal phase, estrogen and progesterone levels drop, and this can be associated with a number of emotional changes, collectively referred to as premenstrual syndrome, or PMS. If you remember, back in BI 232, we said that men, on average, had larger brains, but that women had a higher number of connections between neurons per square inch. That's because both estrogen and progesterone can drive the growth of the dendrites of neurons. With the removal of these hormones, neuron morphology can change, and this can lead to changes in emotions, including dysphoria, that's just a general bad mood, irritability, and even physiological symptoms like bloating. And that's because progesterone gets broken down into aldosterone before it's removed from the body. And as we learned a couple of chapters ago, aldosterone promotes the retention of sodium, which helps to retain water. Back to those dendrites, though. As there are changes to the morphology of neurons, that can lead to a reduction in both serotonin and endorphin signals. Because there are changes in serotonin signaling, SSRIs can be used to treat some of the effects of PMS, which is not to say that PMS is a form of depression. SSRIs can be used to treat all sorts of different conditions that have nothing to do with depression, such as restless leg syndrome. Endorphin levels, those molecules are endogenous opiates. Exercise and crying can both raise endorphin levels, which seems to be a mechanism by which women might be self-medicating to offset the changes that are happening during PMS. So those were the phases of the ovarian cycle. The first 14 days were the follicular phase, characterized by the growth in follicle cells, which increased production of estrogen. Then after ovulation, the follicles turned into the corpus luteum, which secreted both estrogen and progesterone. And it was that progesterone that blocked the production of GnRH, which inhibited subsequent ovulations during the rest of that cycle. While the ovaries are going through the ovarian cycle and producing different levels of estrogen and progesterone, these hormones will be triggering changes in the uterus as well. Let's start first, though, with the connection between the ovaries and the uterus, which are called the uterine tubes, or the fallopian tubes, or the oviducts, depending on how you feel. These will carry ovulated eggs to the uterus. The first portion of the fallopian tubes is the infundibulum. This is the portion that dangles downwards, and it contains fimbriae, or finger-like extensions, which help to catch any ovulated oocytes and make sure that they enter the fallopian tubes. The ampulla of each fallopian tube is the wider portion. You'll notice there's some overlap between the wide ampulla and the infundibulum, which dangles downwards. Which name should you use? Well, it depends if you want to talk about the portion that's hanging downwards or the portion that is wide. The portion that is hanging downwards is also a bit wide. The last part of the fallopian tubes is the isthmus, or the shorter segments. These tubes are lined with an epithelium that secretes mucus and has cilia, which help to propel an ovulated oocyte towards the uterus. Layers of smooth muscle can also help propel an ovulated oocyte. But just like we saw in the digestive system, We don't want these muscle contractions and ciliary movements to be occurring all of the time. Instead, they are triggered by a nerve plexus within the uterus. Fertilization is going to occur normally in the ampulla. So sperm must travel all the way up to reach an ovulated oocyte here. And from there, that fertilized egg will have to survive for about a week before it reaches the uterus. Along the way, the fallopian tubes will have to secrete fluids and nutrients to help protect and nourish that fertilized egg. We'll learn more about the changes that are occurring to that fertilized egg in the next chapter. But for now, after a week, it will reach the uterus where it can implant in the endometrium, which will provide it with physical protection as well as nourishment and remove wastes. The major portion of the uterus is known as the body, while as the top portion is referred to as the fundus, and the most distal portion as the cervix. The opening to the cervix is known as the external os. Sometimes you'll hear reference to an internal os, which is the opening from the cervix to the body of the uterus. The uterus is lined with endometrium, a thick layer of epithelial tissue. But there's also a significant amount of muscle tissue known as the myometrium, and on the very outside is a thin layer of connective tissue called the parametrium. The myometrium is the thickest portion, and the smooth muscle found here is very important during menstruation and childbirth. The endometrium is the inner epithelial lining of the uterus, and it undergoes some very important changes that are occurring at the same time as our stages of the ovarian cycle. The endometrium consists of a basilar zone, which doesn't change, and the functional zone, which undergoes significant changes under the guidance of estrogen and progesterone produced by the ovaries. Estrogen can not only cause the functional zone to grow, it also causes blood vessels to grow into this epithelium. As you remember from BI 231, that's fairly unusual. Most epithelia are avascular. Here's one of our exceptions, the endometrium. The changes that are happening to the endometrium are referred to as the uterine cycle, and these are happening at the same time as the ovarian cycle. During the follicular phase of the ovaries, the uterus will be proliferating. Then, after ovulation, it will switch to a secretory phase. And we've got one extra phase here that we didn't see in the ovarian cycle. The uterus must also go through a menstrual phase, which begins here at the end of the secretory phase and extends here before the proliferative phase. At the end of menstruation, most of the functional zone will have been lost. The basilar zone is still there, and these cells can undergo mitosis to produce a new functional zone. This will be under the control of the hormones estrogen and later progesterone as well. We can now add one more picture to our diagram here, and this new picture represents what's happening in the uterus at the same time as what is occurring in the ovaries. We end with the menstrual phase, where the functional zone is lost. But then, at the same time that the ovaries are going through the follicular phase and estrogen levels are rising, the uterus, specifically the functional zone of the endometrium, will grow in response to that estrogen and become thicker. We call this the proliferative phase. Then, at ovulation, we switch over to the secretory phase of the uterus, where the uterus begins to secrete nutrients and fluids in preparation for the implantation of a fertilized egg that the ovaries have just produced. This is happening under the control of both estrogen and progesterone being produced by this corpus luteum. Therefore, the secretory phase happens at the same time as the luteal phase of the ovaries. And then we had this extra phase here as well. At the end of the secretory phase, if fertilization has not occurred, then menstruation will begin, and this thick endometrial lining will be shed. Let's go over those phases one more time in a different type of cartoon here. During the proliferative phase, rising levels of estrogen will cause the functional zone of the endometrium to grow thicker. It proliferates. This is under the control of estrogen being produced by the follicles that are growing inside of the ovaries. What's more, this estrogen can drive the growth of blood vessels into this epithelial layer. Big blood vessels from the myometrium, it's normal for muscle tissue to have an extensive blood supply, will grow into the endometrium as it starts to produce angiogenic signals. Next up, the role of estrogen is going to change a little bit. When these endometrial cells get both estrogen and progesterone, the hormones being produced by the corpus luteum, they now start differentiating to produce endometrial glands, which will produce secretions that will help to provide nourishment and protection for a fertilized egg that's traveling from the fallopian tubes and could possibly implant into this now thick and highly vascular endometrium. If implantation does not occur, then this thick endometrium will not be needed, and it will be shed by a process called menstruation. One of the first things that will happen is that the endometrial tissue will stop producing the angiogenic signals that promoted the growth of capillaries into the epithelial layer. As this thick epithelium can now no longer get enough nutrients, it begins to die. It does so irregularly, so portions of the endometrium will die at different times. The duration of menstruation is highly variable. It depends on how much tissue was grown in the first place, how quickly hormone levels drop in that female, and how responsive she is to those hormonal changes. Nevertheless, the process of menstruation involves the contraction of smooth muscle of the uterus to remove this dead and dying endometrial tissue, hopefully out the cervix towards the vagina. It's also possible, however, for some of this tissue to wind up traveling up one of the fallopian tubes, because these also constitute exits from the uterus. If you have an obstetrician or a gynecologist, or know somebody who does, I highly recommend asking them, why do women menstruate? Not all mammals do. I don't really have a good answer for that. What I can tell you is that it does not clean the uterus. In fact, women are at a much higher risk for infections right after menstruation. A thicker endometrial lining is actually more protective against yeast and other infections. I can give you a good reason for why women produce a thick endometrium in the first place, though, and that's because human embryos share quite a bit in common with parasites. They can digest epithelial linings, destroying blood vessels, and then deriving nutrients from that blood. They can also trick the immune system, shutting it off in an attempt to protect themselves from an immune response. I'm talking about both embryos and parasites, like a fluke or a tapeworm. So it's very important for the uterus to have this thick endometrial lining so that as the tiny little parasite, the embryo, starts digesting its way through the endometrium, it doesn't actually reach any of the more delicate tissues like the muscle tissue underneath. During menstruation, a significant amount of pain or discomfort may occur, known as menstrual cramps or dysmenorrhea. This can be caused by endometriosis, which I will discuss in a moment. Clots and dead tissue that are too large to easily fit through the cervix can also cause discomfort. But mainly, as the endometrial tissue is dying, it's going to be releasing inflammatory molecules, like prostaglandins, which, as you learned last quarter, can bind to nociceptors and tell the brain that something painful is occurring. Now, one thing to keep in mind when we discuss endometriosis is that the uterus is more or less designed to know that it's going to be getting a high dose of prostaglandins on a fairly regular basis as endometrial tissue dies. This is a normal occurrence. What's going to be an abnormal occurrence is when that endometrial tissue does the same thing in places other than the uterus. Remember that endometrial tissue could get pushed through the cervix, out the vagina, and exit the body. But it was possible that some of that tissue might be pushed up the fallopian tubes. And there's an even smaller chance that some of that endometrial tissue could exit the fallopian tubes and wind up in the abdominal cavity. If that were to happen, one of the more likely places for that endometrial tissue to wind up is the lowest spot in the abdominal cavity, which is the pouch of Douglas back here, or the space between the uterus and the rectum. Now, if that endometrial tissue is dead, it's not going to be a huge problem. The problem of endometriosis really comes into play when that endometrial tissue isn't quite dead. And that's because endometrial cells behave like endometrial cells, no matter where they're located. So if some endometrial cells wind up in the fallopian tube, when the ovaries are undergoing the follicular phase and producing higher levels of estrogen, those endometrial cells will undergo mitosis and start dividing and creating a bigger batch of endometrial cells. This could block a fallopian tube. If it grows big enough, it might even put pressure on the fallopian tube, causing pain. But then when the ovaries stop producing estrogen and progesterone, and the rest of the uterine lining is undergoing the menstrual phase, these awkwardly located endometrial cells in the fallopian tube will begin dying. And as they do, they will produce prostaglandins, just like their friends in the uterus are doing. But unlike the uterus, the fallopian tubes don't really like those prostaglandins much. And this is going to cause a significant amount of pain. How much pain? Well, since we haven't invented a painometer yet, we don't know. And many women don't know how much pain they should be experiencing during menses. Therefore, we don't really know how many women are suffering from endometriosis. There may be a significant number suffering silently and not telling their doctors about the amount of pain that they're experiencing, simply because they have no reference point for how painful it should be. It's been estimated that 5 to 10% of women suffer from endometriosis, but at the time that I'm recording this, we don't have any test for identifying endometrial cells outside of the endometrium. For instance, here, some endometrial cells have left the uterus, exited the fallopian tubes, and wound up on the outside of the vagina here. And the only reason that I know that this is endometriosis is that there's a little arrow pointing me saying endometriosis. I suspect that this discoloration represents death happening to these cells as estrogen and progesterone levels are dropping. Now, I know from firsthand experience that there are people working to develop a diagnostic test for endometriosis, but right now we must rely on patient-reported symptoms. We do, however, have a very good treatment, and that is birth control pills. If the problem with endometriosis is that endometrial cells are in the wrong place, but still responding to the rise and then drop in estrogen by going through a cycle of growth and death, then the solution to that is to make them stop growing and stop dying. And the way we do that is by giving a woman a constant supply of progesterone in the form of a birth control pill or other device. With a constant amount of progesterone, there will be constant levels of progesterone and estrogen, because that progesterone is going to inhibit GnRH secretion. Therefore, if a woman is getting constant estrogen and progesterone from her birth control pill, that is going to stop her from undergoing the menstrual cycle, assuming, of course, that she doesn't take the placebos. That endometriosis will not grow as much because estrogen levels don't ever rise, and they also won't die because they will constantly be getting their happy growth hormones that say, keep surviving, little endometrial cell. And this doesn't get rid of the endometriosis, but it gets rid of the death phase that triggers all of the pain and discomfort. Birth control pills can therefore be used to do more than control births. They can help treat endometriosis and a number of other conditions. Nevertheless, we still call them birth control pills rather than progesterone with or without estrogen. And for that reason, anybody who's against controlling births is going to be against allowing women easy access to these medications. In the state that I live in, women can get birth control pills from their pharmacist. But I think we're in the minority. In most other states, women must get a prescription from their doctor and jump through a certain number of other hoops. Maybe if we just changed the name from birth control to something around, progesterone pills, there wouldn't be so much controversy. I'm not really sure, and I'm really stepping outside the boundaries of anatomy and physiology. The cycle of growth and death in the endometrial lining of the uterus begins when the ovaries first begin producing high levels of estrogen and progesterone, and that's known as menarche, or the first uterine cycle. Because there aren't that many follicles growing initially, the first uterine cycles may be fairly small and insignificant, but then will build in size as more and more follicles are recruited and begin producing even higher levels of estrogen and progesterone. Hence, we get even bigger changes in the amount of estrogen and progesterone at different times during the uterine cycle. Eventually, the ovaries will run out of follicles. There's only a certain number, which was different from the stem cells in the male testes. Hence, around the age of 45 to 55-ish, women will undergo menopause, or the cessation of the production of estrogen and progesterone, which will stop the uterus from undergoing its monthly cycle. If the uterus stops its monthly cycle at some time after menarche but before menopause, we call this amenorrhea. This could either be a sign of bad health, or it could be caused by medications. For instance, amenorrhea can be triggered by a drop in body fat, and then the body apparently can sense that it really shouldn't be getting pregnant at any time because it doesn't have enough energy reserves to support a new life, and this will stop the uterine cycle. So we covered the ovarian cycle, which had just two sections, the follicular phase and the luteal phase, which were separated by ovulation. There were also changes happening to the uterus at the same time, which we called the uterine cycle, which had a proliferative and a secretory phase separated by ovulation. And then this extra phase, the menstrual phase, which I'm not really sure where to put. Do we put it at the end of the secretory phase or here before the proliferative phase? Well, it's happening at both times. And then we also discussed endometriosis and what happens when endometrial cells wind up in some place other than the uterus. Next in our tour of the female reproductive system is the cervix and its connection to the vagina. The fornix are the regions of the vagina that surround the outer edges of the cervix. This little anatomical region was much more important back when diaphragms were a popular form of birth control. But for now, it's just these little edges that you're going to see over here and over here. The cervix is not just a connection between the uterus and the vagina. The epithelial cells here can produce mucus. They do not produce this all of the time. After ovulation, mucus secretions increase, which will create a mucus plug, which will separate the uterus from the vagina. Therefore, anything that can be found here in the vagina, like yeast, for instance, are going to have a much harder time getting into the uterus. This happens after implantation and helps to protect the developing embryo. Here on the left, we see a view from the vagina looking onto the cervix. And at this point, we must be in the follicular phase of the ovarian cycle, or the proliferative phase of the uterine cycle, because the cervical os is open. After ovulation, when we enter the secretory phase of the uterine cycle, one of the important secretions that is produced is mucus down here in the cervix, which creates a mucus plug, preventing anything from in here, the vagina, from entering through the cervix into the uterus, which could damage the developing embryo. Do you remember back when we were discussing the digestive tract, where I said that colon cancer was the most common cancer type found within the digestive system? Now, the entire tract was lined with epithelial cells, and because these cells undergo mitosis quite frequently, they're at a higher risk for becoming cancerous than other types of cells in the body. And yet, where did cancers arise in the digestive tract? Did they arise in the esophagus, or the stomach, or the duodenum? Well, they can, but that's pretty infrequent. They mostly arose in the colon. So why did they do that? Well, if I knew the answer to that, I would not be sitting here in my living room recording lectures on my weekend. I'd be on my yacht sipping martinis in my nautical-themed pashmina. Nevertheless, I can tell you that we know that cancers arise in one location more than others. And in the female reproductive tract, even though the fallopian tubes and the uterus and the cervix and the vagina are all lined by epithelial cells, for whatever reason, it's the cervix that's more likely to become cancerous. To detect these cancers early, rather than later when you can't undergo chemotherapy and operations, a man in Greece developed the pap smear. The first three letters are the same first three letters in his last name, and boy, I don't want to try and pronounce that right now. But he developed this procedure back in 1927. Scraping some of the epithelial cells off the cervix and looking at them under the microscope can help identify whether they look normal or cancerous. Cervical cancer is still the #1 cause of cancer-related deaths in women in developing countries. And even here in a first world country, there are still a number of cervical cancers that are detected every year, which is why it's been recommended that all sexually active women get screened for cervical cancer every 3 to 5 years. Almost all cervical cancers are caused by this virus here, which is kind of weird. Most cancers arise by mutations caused by errors in mitosis or by carcinogens in the environment. This is one that's caused by a virus that integrates into our DNA. But this procedure here can detect when this goes wrong, and it's very effective at detecting the cancer early, which allows for its removal. Just like colon cancer screening, the pap smear is highly effective at saving lives. In fact, science can count the number of lives saved and the amount of years that women live longer if they undergo regular pap smears than if they didn't. Nevertheless, in recent times, the need for pap smears has decreased a little bit because of the HPV vaccine, which is highly effective at preventing the infections that might cause cervical cancer in the first place. Nevertheless, because the pap smear is so cheap and so effective, even women who've had the HPV vaccine are still recommended to get pap smears on a regular basis. But with these two items here in play, here in the United States, the number of women who are dying from cervical cancer is decreasing significantly. Ooh, wait, I need to clarify that a little bit. That previous statement was true if you identify as white. Here in the United States, we are getting very good at preventing cervical cancer if you're white, and getting very good at preventing you from dying from cervical cancer if you're white, but not so good if you're black. And that's probably due to our unequal access to healthcare. Yeah, but I'm kind of wandering off on a tangent that's more sociological. And of course, you're paying me for my knowledge of physiology. So let's return to class material. We have left the cervix. We now enter the vagina, which is a muscular tube. It's an internal structure. And this is in contrast to what most people would refer to as a vagina, an external structure that they can see in pictures and movies. The vagina is actually an internal muscular tube. The vagina serves as an exit from the uterus for both menstrual fluid and babies, as well as an entrance for semen into the uterus. There's also a large number of nerve endings here, roughly 4,000, depending on which woman you are measuring. And just like we've seen this term with the urinary tract and the digestive tract, the vagina has an epithelial lining and a bunch of subepithelial glands which produce a number of important secretions. This includes the movement of water and other molecules into the lumen of the vagina, including the movement of protons, which helps to keep an acidic environment within the vagina, which helps to slow the growth of a number of microorganisms, at least microorganisms that don't prefer these acidic environments, such as a number of bacteria and funguses that our bodies have allowed to colonize the vagina. So just like the colon has its own flora, the vagina has its own flora as well, which helps to reduce colonization and infection by bad bacteria, funguses, or other microorganisms. For this reason, it is not recommended that women remove these endogenous flora from their vagina by douching. At birth, the entrance from the vestibule to the vagina can be either fully or partially blocked by an epithelial lining called the hymen. This epithelial lining may be damaged and perforated by sexual intercourse, or it might not. But there are a number of other things that can damage this epithelium. Any sort of physical trauma besides sexual intercourse can do this as well, including physical activity, which here in the United States, thanks to Title IX, many young women are engaging in physical activities known as sports. Therefore, the absence or presence of a hymen is a very bad indicator for sexual activity, and under no circumstances should be looked for to try and determine whether a young woman has had sex or not. In this slide here, I'd like to point out a little bit of sexual homology, and by that I mean similarities between men and women. The uterus and vagina were lined by smooth muscle, but there are a number of important skeletal muscles near the reproductive tract. And even though we think of skeletal muscles as being controlled by conscious activity, it's not entirely true that we have control over these muscles whenever we want to. And in fact, contraction of a number of vaginal muscles, or skeletal muscles near the vagina, occur during sexual intercourse, including these two bulbospongiosus muscles here on either side of the vagina. I just want to point out here that these are the bulbospongiosus muscles in the male reproductive system, here lining the penis. As we're going to see in the next chapter, there's a significant amount of homology between the female and male reproductive tracts. In fact, it's almost entirely the same structures, just in slightly different locations and with slightly different functions. Just like in the uterus, the inner lining of the vagina was fairly thick. It is a stratified squamous epithelium, which is very similar to the stratified squamous epithelium of our skin, only here in the vagina it is non-keratinized, meaning it is moist and the cells at the surface are not completely dead. The mucosa, which includes a bit of connective tissue underneath the epithelial tissue, includes a number of elastic fibers, which provides the vagina with the ability to stretch and then retract to its original size. And that can change depending on whether there is an object inside of the vagina, such as a penis during heterosexual intercourse, or a baby during childbirth. Now that wraps up most of the internal anatomy of the female reproductive system. In this last little section, we covered the cervix and the vagina. And next, we're going to move on to some of the external anatomy, and then a bunch of physiology. But before we do, this would be a good time to take a break and take a rest, and come back when you're ready for the next hour or so of the lecture. Okay, welcome back. In this second section, I'll discuss the difference between ejaculation and orgasm, which in men are tightly linked occurrences, but in women are easily segregated into two distinct physiological activities. I'll discuss the vulva, which many people refer to as the vagina, but that's not anatomically correct. We'll talk about the functions of the clitoris, which is the only organ, in either men or women, that is strictly involved in sex. We'll talk about breasts and mammograms and why there is controversy over who should get mammograms and why. We'll talk about menopause and ways to delay the onset of menopause. And we might talk about why grandma has birth control pills, even though she's obviously not going to be getting pregnant. To do all of that, we will continue with the external female anatomy, including the structures of the vulva and a few glands. We'll move on to the breasts and then talk about some physiology. The mons pubis is a region of skin just above the vulva, or the external genitalia. And here you find pubic hair, and subcutaneous to the skin is a bunch of adipose tissue, which creates a mounding or mons-like shape to this region, hence its name. The labia majora are the outer limits of the external genitalia, which are referred to as the vulva. The labia majora contain a number of sebaceous and apocrine glands, which secrete substances to the surface of the labia. The vulva constitutes all of the external female genitalia, including the labia majora and the labia minora. and the space in between the labia minora, which is referred to as the vestibule. That word that we've also used for the oral and nasal cavities in previous chapters. Inside the vestibule are a couple of important glands, as well as the openings to the urethra and the vaginal orifice here. Off to the sides of the urethra are a pair of glands known as the paraurethral glands. That's their name based on location. You can also call them the Skene's glands based off of who discovered them, or the female prostate based off of what they do. There are a number of nerve endings here, hence this is a highly sensitive spot for many, but not all women, which is often referred to as the G-spot. The G stands for Grafenberg, one of the earlier researchers to have discovered this location. There's a lot of argument over whether this actually exists. Yes, it does. We have anatomical evidence, and we have had such for hundreds of years. But here in the United States, the idea that there's a part of the female body that is responsible for women enjoying sex comes with some controversy. That controversy is not based in science. There's definitely a bunch of nerve endings here. The female prostate does what the male prostate does, which is to produce fluid secretions upon ejaculation. These secretions in the females include the prostate-specific antigen, the same molecule that was produced by the male prostate gland. Another pair of glands exist off to the sides of the vaginal orifice, and these are called the greater vestibular glands. And they are homologs to the bulbourethral glands found in males. And just like in the male reproductive system, they produce a mucus-rich material which helps to lubricate the reproductive tract during sexual intercourse. Shown here is a diagram of the clitoris, which, as we will learn in the next chapter, is the same embryological structure as the penis, meaning it's got a pair of corpora cavernosa and corpora spongiosa as well. Shown on the dotted line here is where you would find the labia minora, which forms a hood over the only portion of the clitoris visible from the external portion of the female body. This portion is known as the glans clitoris. The function of the clitoris is strictly to trigger sexual arousal and orgasm. And there may be twice as many nerve endings here in the clitoris as found in the penis. The glans, again, is the only visible portion, but then inside the body is a singular shaft, which then extends into a pair of crura. And then there's also a pair of vestibular bulbs here, or clitoral bulbs. These are the homologs of the corpora spongiosa because they border the urethra. These have been called the vestibular bulbs because they line the outer edges of the vestibule, but it's a better name to call them clitoral bulbs because they are erectile tissue and part of the clitoris. The internal portion of the clitoris has also been referred to as the perineal sponge. This is all just erectile tissue, the same type of tissue found in the corpora cavernosa and spongiosa of the penis. The major difference here, though, is that the clitoris is mostly internal. What you might notice is that this image here may look a lot larger than what you see on the models in the anatomy classroom. And that's because anatomy models are typically designed off of studies from cadavers. And most cadavers died after menopause. And when you remove estrogen and progesterone for decades, these tissues do shrink in size. But in a living premenopausal woman, the clitoris is actually a fairly large organ, extending all the way from the anterior surface all the way back close to the rectum. So that's the vulva, plus a couple of glands in the female reproductive system, the greater vestibular glands, and the Skene's glands, or the female prostate. Now you may wonder where the homologue is for the seminal glands, and in the next chapter we'll learn that those glands in the male, along with the vas deferens, disappear in females. But these two glands here are found in both men and women. They just get different names and have slightly different locations. Next up are the mammary glands, which are a pair of glands which can produce a specialized form of sweat known as breast milk, which can provide nutrients to a newborn infant. These secretions are distributed through a pair of nipples, which are surrounded by a region of pigmented skin called the areola, which is not to be confused with areolar connective tissue. This is indeed pigmented epithelium. The glandular epithelium of each breast secretes its materials into a number of ducts. Roughly 15 to 20 of these connect to each nipple. Prior to the ejection point is a region where the ducts widen, which are known as the lactiferous sinuses. The support and the shape of the breasts is maintained by a network of dense connective tissue called the suspensory ligaments of the breasts. This is dense, irregular, or regular connective tissue, as is found in ligaments and tendons. There can also be a fair amount of loose connective tissues, such as areolar connective tissue, which can separate the individual lobes from one another, as well as separate breast tissue from underlying muscle tissue. The suspensory ligaments will ultimately anchor the breast tissue to the underlying fascia, another region of dense connective tissue in the body. Damage to these ligaments can cause ptosis, or sagging of the breasts, although a more common reason for sagging to occur is rapid growth of breast tissue during pregnancy, followed by a reduction in that glandular tissue after pregnancy. Breastfeeding is not a contributing factor. Whether women breastfeed or not is irrelevant. If they get pregnant, then their hormones, like estrogen and progesterone, will drive growth of breast tissue, but then when that is no longer needed, those hormone levels will drop and breast tissue will involute or reduce in size, which can lead to sagging. Suspensory ligaments can complicate mammograms. Mammograms are an early detection method for breast cancer. Because the breasts are predominantly soft tissue, epithelial and adipose tissue, X-rays will pass through them fairly easily. However, cancer cells typically undergo some metabolic quirks and wind up leaving calcium deposits, which can show up on an X-ray known as a mammogram. Unfortunately, dense connective tissues can also show up on X-rays. So the more dense connective tissue breasts have, the more likely they are to show up with false positives on a mammogram. And that means that younger breasts and smaller breasts are typically denser and have less of the loose tissues like adipose and epithelium, and have relatively more of the dense tissues, the dense regular and irregular connective tissue. Hence, they absorb more X-rays and can either mask tumors that are nearby or possibly look like tumors even though they aren't. For that reason, it's fairly difficult to give a blanket statement to all women as to when they should start having a mammogram. It used to be said that all women over the age of 40 should get an annual mammogram, but recently the U.S. Preventative Services Task Force bumped that up to the age of 50 here. And they said that for women ages 40 to 50, it's going to depend on the individual. So what will it depend on? Well, possibly family history and genetics, but also possibly breast size. Larger, softer breasts are going to be easier to detect tumors in than smaller, denser breasts. So women with smaller, denser breasts, if they don't have any other contributing factors like family history, are typically recommended to wait until the age of 50, at least by this group here. Now there are a number of other groups who have advice on breast cancer. Recently, and this was a big shock to me, the Komen Foundation for the Cure changed their guidelines to match this government task force here. Shortly after that, the American Cancer Society did this quirky thing, and rather than choosing the age of 40, the older age, or the age of 50, the newer age, if you will, that was recommended, they went halfway in between, making things even more complicated. And the National Cancer Institute really isn't sure at all what they want to recommend anymore. Bottom line is that many of your female patients are going to be confused because there are a number of very good agencies here recommending different things. And so you're going to have to help clarify what the controversy is and maybe provide them with a overly simplistic answer. So what's the controversy? Surely detecting a tumor earlier is always better than later. Well, let me play devil's advocate really quickly. If earlier is always better, then why not start at the age of 30 instead of 40? And if earlier is better, then let's bump it up to age 20. Why not yearly mammograms starting then? And heck, why not age 10? Why don't 10-year-olds get mammograms? Well, obviously because they don't have breasts, and therefore they're not going to have breast cancer. So the question becomes, when is the optimal age to undergo regular screening for breast cancer? And the answer to that is complicated. This image here should illustrate a little bit of the complicating factors. Some breast tumors are going to be growing so fast that it really doesn't matter when you detect that cancer. You're never going to be able to do anything about it. It's going to grow so fast that by the time you detect it, it's already too late. And some tumors grow very slowly. Some of them aren't going to grow at all. So who cares whether you detect these tumors at the age of 40 or 50 or 60 or 70? They're not going to change. And the slow-growing ones, again, who cares when you detect these tumors? They are growing so slowly that they wouldn't kill your patient until they reached the age of 120 or something. And there's a much better chance they're going to die from heart disease long before then. So ideally, a mammogram will detect a tumor at an early age, and this tumor might kill this woman before she dies of heart disease, but because you've detected it early, you could get rid of it and allow her to live till the age when she dies from other things like heart disease. It's been estimated, though, that very few breast tumors are of this ideal type. Slow growing, but not so slow growing that we can ignore them. On the opposite end of the spectrum, annual mammograms expose women to X-rays, and those X-rays could be causing cancers. So we don't want to overexpose women to X-rays. Let's go through a little story here. Switch over to men. I've got two hypothetical patients, Steve and Bill, and they're identical twins, and both of them develop the exact same cancer at the age of 40. Steve, however, goes in for early treatment and gets, let's say prostate cancer screening at the age of 40, and they detect his tumor, and he undergoes chemotherapy at the age of 45, and the tumor goes away. But then, years later, it comes back, and like many cancers that recur, they come back really nasty. So at the age of 69, he gets the cancer again and dies a year later. His brother Bill, who has the same tumor, doesn't go for early cancer screening. And so that tumor that begins at the same time grows slowly until it's so massive that by the age of 69, he starts getting really horrible symptoms. He goes into the hospital and the doctors say, "Man, you should have come in for screening. We could have done something had we detected this earlier, but now it's too late." And he also dies by the age of 70. So the question is, did the early screening that Steve got help him or not? And that depends on how you do the numbers. If you want to report overall survival, you would say that Steve, who got diagnosed at the age of 45, lived for another, 25 years, 35 years? Oh, I think I did my math wrong. I think we have to change this to a 25 there. He lived for 25 years after his initial cancer diagnosis, whereas Bill only lived for 1 year. So we would say that for overall survival, this early detection allowed Steve to live for 25 times as long as Bill did following a cancer diagnosis. Of course, they both died at the age of 70, so if you measure overall mortality, you would say that this early diagnosis did nothing. It didn't really help Steve live any longer. He just went through a fairly expensive treatment and lived to the same age as his brother Bill. Now, I'm not going to test you on the difference between overall survival and overall mortality, but I do want to introduce you to the concept that numbers can be tweaked to be misleading. So let's contrast the mammogram with the pap smear. And what we can clearly say is that the pap smear saves lives. And once the pap smear was introduced into the United States, or later into Great Britain, the number of women dying from cervical cancer plummeted. And it's been absolutely clear since its invention that this early cancer detection test saves lives. What's more is we're now learning that vaccinating is also saving lives on top of this early cancer detection test. And the HPV vaccine is one of our more effective vaccines out there. And it's leading to a significant drop in infections. And I suspect that this will go down even further once more boys are getting vaccinated, in addition to girls. On the other hand, breast cancer screening has not led to a noticeable drop in breast cancer-related deaths. Here on the left, we see a report from the World Health Organization that shows when breast cancer screening was introduced into a few different European countries and the overall number of deaths due to breast cancer. And we see that there wasn't a change in breast cancer deaths whether a country adopted mammograms early versus mammograms later. On the other hand, cervical cancer screening, when it was introduced in Great Britain, led to a very clear and precipitous drop in the number of deaths due to cervical cancer almost immediately following its introduction. So that was a very cursory introduction to the current controversy over mammograms. And what I would like to leave you with is that it's complicated. You're going to have to give different advice to different women based off of their breast size and shape and their family history. And they may not like those sort of gray areas. But what if a woman does get breast cancer? Well, one of our most common treatments is a mastectomy, or a removal of that breast tissue. To prevent this, it's possible that we could avoid exposure to carcinogens that might cause breast cancer. And there's a certain amount of interest in chemicals that we might be exposed to that increase our risk of breast cancer. But some recent studies on cell division and cancers suggest that there might not be much that we can do to actually reduce breast cancer here in the United States. Simply rapidly dividing epithelial cells are going to make mistakes in DNA replication that are going to lead to breast cancer at some point, which may require removal of that breast tissue by mastectomy, or removal of just some of the breast tissue by lumpectomy, possibly followed by radiation or chemotherapy. A lumpectomy would be removal of just some of the breast tissue, whereas mastectomy would be removal of all of the breast tissue. This may or may not include underlying tissue, such as lymphatic tissue underneath the breast. It's fairly common to biopsy what is called the sentinel lymph node. All of the lymph nodes in the breast ultimately drain into a single lymph node called the sentinel lymph node. So if you're worried that breast cancer has spread to other parts of the body, then biopsying the sentinel lymph node can tell you whether it has spread. If it's gotten to this lymph node, then it's probably gone elsewhere in the body, and this will require chemotherapy after surgery. Whereas if this lymph node is clean, then it's possible for a woman to simply undergo removal of that cancer via mastectomy or lumpectomy. Now, the nipples may or may not be removed during this procedure. Nipple tissue actually is unrelated to breast tissue, so even if the breast tissue has become cancerous, it's possible to spare the nipples and be fairly certain that they do not contain any breast cancer cells, because they are not the same type of tissue. Historically, it was thought that removing more tissue was always better. This kind of mimics the idea that early detection is always better, and what we're learning is that more is not always better. Up until the 1970s, one of the most common treatments for breast cancer was called a radical mastectomy, which not only removed all of the breast tissue, but underlying connective tissue, muscle tissue, and sometimes even bone tissue in the form of the clavicles and ribs. And this greatly reduces the function of body parts like the arms. Without pectoralis muscles or clavicles, the arms cannot adduct. It was this gentleman here that did the radical experiment to see whether this was actually working. And as I understand it, he was ostracized for a long time. Everybody just assumed that more was better. But he tried comparing the radical mastectomy to much more minor surgeries like a lumpectomy, and found that removing more tissue did not improve results. The radical mastectomy still led to the same number of deaths as a lumpectomy, and conversely, both surgeries saved the same number of lives. Breast tissue can also be removed in a breast reduction surgery, which can help alleviate stress placed on the lower back. Conversely, breasts can be enlarged, either for cosmetic purposes, or for reconstruction following a mastectomy, or in gender reassignment surgeries. In these cases, a plastic bag full of silicone or saline can be placed under the existing glandular tissue in the case of breast enlargement surgeries. But if that glandular tissue does not exist or no longer exists, then the bag can be placed under the pectoralis muscle, keeping it as far away from the surface of the breast as possible. A plastic bag full of silicone will not trigger an immune response. Similarly, other very simple chemicals will not trigger an immune response, like titanium implants used in hip replacements, or even a gold or silver coated earring will not trigger an inflammatory response by white blood cells. However, the body can recognize foreign objects, even if lymphocytes can't recognize any antigens on the surface. And when the immune system detects such a foreign object, it will often trigger activity of fibroblasts to produce a bunch of scar tissue to encapsulate that object. In this picture here, we see that that has happened to the silicone implant over here. And over time, scar tissue tends to shrink. And so what's happening here in this woman's breast is that scar tissue has encapsulated the implant and is now shrinking over time, forcing that silicone bag to adopt more of a spherical shape rather than the more traditional breast-like shape. It would be much harder to visualize this happening to a hip replacement surgery, but the same thing can happen there. Scar tissue can form, and over years that might not be noticeable until the scar tissue shrinks and starts putting pressure in that area. This is known as encapsulation. So that was some physiology related to the breasts, including the function of the suspensory ligaments and how they can complicate mammograms, and a few breast-related surgeries, including mastectomy and breast enlargement. The last portion of this lecture covers the physiology of the reproductive system in action. This image here is an MRI, and researchers wanted to take pictures of the internal reproductive anatomy of men and women engaged in heterosexual intercourse. As you may know, if you put people into an MRI, you have to tell them to be still while the machine takes its images. And as you may also know, lying perfectly still does not exactly work well during sexual intercourse. Hence, the next image that I'm going to show you should seem all the more significant. And here we see an MRI of a man and a woman engaged in sexual intercourse. A couple of things to point out is the uterus here. Take a look at the anatomy models, for instance the ones in the lab reference, and look at the direction that the uterus is pointing, and you might notice some differences here as to where the opening of the cervix is. This just illustrates that a lot of this internal anatomy can change position during sexual intercourse. Another thing to pay attention to here is the penis. It's making a 90-degree angle, and as many men will tell you, that's not exactly what their penis does. Well, that is, of course, if you think of the penis as only the external or shaft portion. What we are looking at here is the shaft and the internal portion, or the crura. So it's not like this is the external part of the penis making a 90-degree angle. This is the entire organ, and it's not a straight or linear organ. Nevertheless, in both men and women, parasympathetic activity is going to lead to an increase in blood flow to these structures here, the clitoris and the penis, which in men leads to an erection, and in women changes the orientation of the glands relative to the rest of the external anatomy. And sympathetic stimulation will trigger ejaculation by the various glands involved in orgasm. Of course, orgasm is actually going to be separate from ejaculation. Ejaculation refers to the fluids secreted by the various glands of the reproductive tract. In men, that's the seminal vesicles and the prostate gland that are involved in ejaculation. The bulbourethral glands, which were located roughly around here, were involved in producing mucus prior to ejaculation. To get these fluids to travel down the urethra will require both peristaltic contractions as well as contractions of nearby skeletal muscles to help propel these fluids. A number of skeletal muscles can assist with those smooth muscles in ejaculation. For instance, the ischiocavernosus, bulbospongiosus, and pubococcygeal muscles can help to propel fluids down the urethra, simply by providing some muscular tone and squeezing those tubes. Contraction of these muscles can also trigger the central nervous system to register pleasurable sensations. These muscles are part of the pelvic floor, and muscle tone can contribute to the retention of feces in the rectum and retention of urine in the bladder. Damage to these muscles can lead to incontinence. Hence, Kegel exercises were devised to increase muscle strength to these pelvic floor muscles to help reduce urinary incontinence. One of the side effects of increased muscle tone to these pelvic floor muscles is that it also tends to increase pleasurable sensations during sexual intercourse. Hence, many people associate Kegel exercises with sexual intercourse rather than their initial invention to help prevent urinary incontinence. Ejaculation, therefore, is strictly glandular and muscular around the reproductive tract. Orgasm, on the other hand, involves the central nervous system. A number of changes will be occurring in the brain during an orgasm. In men, this happens at the same time as ejaculation, hence people get the two confused, but in women they are not necessarily linked, and in fact orgasms can occur frequently in women. This involves the vagus nerve, which means that even people with full spinal paralysis can have an orgasm even if they can't feel anything around their reproductive tract. And typically this involves inhibition of a number of limbic areas, in particular the fear center like the amygdala, and another area, the prefrontal cortex, which is involved in decision making. Hence, the sex and decision making generally don't go too well together. But a number of other brain activities have to increase their function significantly, especially the cerebellum, which is involved in coordinating muscular activity, and the nucleus accumbens as well, which was the pleasure center of the brain. One major difference between men and women is activity of the occipital lobe. Women will typically have high activity in the occipital lobe during orgasm, whereas men will not. Hence, many women will describe orgasms in visual terms, like, I saw fireworks or stars, whereas men do not. Release of oxytocin also happens with an orgasm, and oxytocin was one of our pair bonding hormones, if you will. Oxytocin and activation of the vagus nerve can also trigger smooth muscle activity in the uterus, triggering reverse peristaltic waves. We're not really sure what the smooth muscle activity is for, or even if it really has a function in humans. There are two major theories. One, maybe that reverse peristalsis helps to pull semen up through the vagina into the uterus and up the fallopian tubes. This is known as the upsuck theory, but there's just no scientific evidence in humans that a woman experiencing an orgasm will have an increased chance of being impregnated during heterosexual intercourse. Another major theory is called the pole-axe theory, and this revolves around the idea that oxytocin typically inhibits a lot of other brain regions. Hence, after an orgasm, a woman might be more likely to just be fine with sitting and lying down, rather than standing up and possibly allowing semen to leak out of her uterus and vagina. Once again, there's no evidence that this will actually increase rates of fertilization, but these are two cute theories, and they have kind of quirky names. The release of oxytocin in the brain of males will trigger a refractory period. This will inhibit erection by inhibiting parasympathetic tone to the penis, and also inhibit further ejaculation events. The time period in which this lasts is highly variable. For younger men, it's typically much shorter. For longer men, it typically lasts for longer. Now, in the old days, we learned that the sexual peak of men was around the age of 18, but for women around the age of 40. But the question remains, how did they measure sexual peak? And it turns out it was the minimal refractory period, meaning the shortest amount of time between when you were aroused and could ejaculate. Now, not everybody would agree that a 5-minute refractory period is the best between when you're first aroused and then you finally ejaculate, but in younger men, that's a shorter time period. One thing that I find interesting is that the oxytocin release also switches how the brain perceives information coming from the penis, especially the glands of the penis. Touching the glands of the penis initially can be quite pleasurable, but following orgasm, it now switches from perceiving this as pleasurable to uncomfortable or even painful. The reason I find this interesting is it could help us to explain chronic pain, people who suffer pain even though they aren't injured. It's obvious, at least here, that the brain can sense pain even in the absence of injury based on the situation. Oxytocin has a number of different jobs, which I covered in BI 231. It's also released during labor, which can trigger smooth muscle contractions of the uterus, this time pushing babies out rather than pulling semen in. Oxytocin is also released when the nipples are stimulated and triggers the letdown reflex in women whose breasts have been primed to lactate prior. It is also involved in orgasm, as we learned, and as a pair bonding hormone. It helps people to form connections with other people, especially people that they are near when they are having an orgasm. Now, some people will call this the love hormone, and I just want to remind you that it's also involved in hatred and fear as well. So it's involved in all sorts of human interactions, not just the positive ones. As the reproductive system gets older, epithelial cells don't divide as fast as they used to, and that can lead to changes in the lining of the reproductive tracts and the amount of fluids that they are capable of secreting. This drops precipitously in women after menopause when their ovaries are no longer capable of producing estrogen and progesterone, the hormones that trigger the functions of the female reproductive tract. Testosterone levels in men also decrease with age, but there's no cutoff point for testosterone production the way that we see in women. The reason that women go through menopause is that all of their stem cells in the ovaries underwent meiosis prior to birth. Hence, there were a limited number of primordial follicles. Many of those died before that woman even reached puberty, before they could develop further and be ovulated. But with each subsequent cycle of the ovarian cycle, a number of those follicles were lost, either to ovulation or just when a couple of them became dominant and caused a number of the others to die. Around the age of 45 to 55, women will have lost all of their follicles. Hence, with no more follicle cells, they can no longer produce levels of estrogen and progesterone. And this is what we call menopause. This doesn't happen all at once as a woman loses follicles and doesn't have enough to maintain the same levels of estrogen and progesterone. She goes through periomenopause, or the time before menopause. A reduction in estrogen and progesterone can inhibit the function of any tissue that responds to those hormones. This includes a reduction in the size of the epithelium of the uterus and breasts. It can also lead to a thinning of the epithelial lining of the urethra and the vagina, as well as a reduction in their secretions, which can make for difficulty during intercourse. Estrogen also promotes bone growth, hence during menopause, with the reduction in estrogen levels, this can contribute to osteoporosis. Estrogen also affects a whole bunch of locations in the brain, especially the hypothalamus. So when we take this hormone away, it can change the function of the hypothalamus, which in turn leads to hot flashes, or increased vasodilation in the skin, which leads to the perception that the body is much warmer than it just was. As I understand it, if you want to experience what a hot flash is like, eating a hot pepper full of capsaicin can trigger the same sort of reflex. Smoking and other stresses can cause menopause to occur sooner than average, whereas anything that inhibits ovulation can delay menopause. Inhibiting ovulation means that fewer follicles are going to be lost. Hence, follicle cells are going to remain for longer in that woman's life. Hence, they will be sticking around for longer, producing estrogen and progesterone. Therefore, the use of oral contraceptives or a number of pregnancies and breastfeeding can all inhibit ovulation, and they all inhibit or delay the onset of menopause. Treatments for menopause focus on trying to replace the hormones that are lost, both estrogen and or progesterone. Back in the 90s and early 2000s, this was done with high doses of equine estrogens and progesterones, known as hormone replacement therapy. But it was discovered that this increased the risk for breast cancer and heart disease. Now, these studies weren't well designed, and in fact, there were a number of problems with them. So even after the Women's Health Initiative came out and said that hormone replacement therapy was bad, and the entire medical community almost overnight stopped issuing hormone replacement therapy, these days, some researchers and doctors are going back to look at the data a little bit more closely. And that's based off of the idea that estrogen and progesterone maybe can inhibit some of these diseases. Maybe not at the same high dose that was done in these experiments, and maybe not done in the same way, waiting for women to go through menopause for years before replacing these hormones. So these days, some women are going on hormone replacement therapy with a much lower dose of hormones, possibly even the form of birth control pills. So somebody might be taking birth control pills after menopause, even though they have no chance of getting pregnant because they have no more follicles left to ovulate, because the low dose of estrogen and progesterone helps to inhibit all of the symptoms that we covered on the previous slide. Instead of taking birth control pills, there are other chemicals that can mimic and or inhibit estrogen. Here's one of the weird ones. Tamoxifen, which blocks estrogen signaling, can also alleviate some of the symptoms caused by loss of estrogen. And if that doesn't really make sense, well, it shouldn't, but that's the endocrine system for you. Other options might include phytoestrogens. A number of plants make chemicals that are very similar to estrogen, including soy and flaxseed. But that's going to wrap up this chapter on the female reproductive system, which means we've only got one more to go before the year is over.